1,000 miles.
Well, welcome.
All right.
Introduce yourself.
All right. Sure. So my name is Kirubel Tefera. I'm a medical oncologist with the trials group here in Cincinnati. Thank you for inviting me. And the topic that we like to discuss is today. As a medical oncologist, most of the time when it comes to prostate cancer, we do see metastasized prostate cancer. So that will be the topic of the day today. Hopefully we can have a good discussion, get something out of it, from it. So let's go into it. Let's start first by the statistics of this disease. This is, as most of you are aware, this is the most common cancer after skin cancer in men. About 29% of all males who have diagnosis of cancer have prostate cancer. And according to the NIH, there are about 161 cases last year. Unfortunately, we have lost 27,000 people from it. If you go a little bit more on the same thing with NIH data, about 11.6% of male population would eventually diagnose with prostate cancer. So that puts us about 1 in 9 males in their lifetime, they would develop prostate cancer. And let's see if I can touch. The pinpointer would be, is it right there?
Yes, oh, the pointer is right there, the red one.
This one, okay. So 60% of the cases are diagnosed at age over 65, and then this disease is, fortunately, is rare on younger populations. I'll show a little more graph here. I borrowed this graph with one of my colleagues in genetic departments here. This shows you the breakdown of the disease on age groups. You can see almost 90% of the cases, this disease diagnosis on age greater than 55. About 10% of them is less than 55, and as I said, it's pretty rare for anybody less than 40. The risk factor for prostate cancer, as we discussed in the most important risk factor is age. As I said, the average diagnosis is at the age of 66. And also race is going to have the second most important role. African Americans tend to have a higher risk of this disease compared to other groups. And then 70% more chances compared to the white populations in terms of developing the prostate cancer. The other factors are family history. You have a twofold increase if your first relative is diagnosed with disease. And to the lesser extent, supplemental testosterone use and also diets can play in, but those are like kind of questionable. But the strongest is age and ethnic backgrounds and genetic at the bottom. This PCIG, BRCA1 and BRCA2 usually associated with ovarian cancer and breast cancer, and also other rare kind of cancer, but it is also associated with prostate cancer. Diagnosis, there are multiple ways we diagnose. For almost all cancers, the diagnosis is based on a pathology or biopsy. There's no exception for prostate cancer. The only exception is when a person has a very, very high prostate antigen level. That can be a diagnostic also. Clinically, patient can diagnose with hyperplasia symptom, that is increased frequency. And in a metastasis setting also, since prostate cancer is likely to go to the bones, you can see bone pain would be happening. But the biopsy, especially for local diseases, is a necessity. But if it's spread in and there's a very high PSA level, a diagnosis can be made. So the next thing I wanted to talk about is how do we stage cancers, especially prostate cancer, because this is very important because mortality is associated with the stage of the disease at the time of diagnosis. What do I mean by? At the time of diagnosis, if the patient has stage 1 disease, stage 2 disease, stage 3 disease, stage 4 disease, that actually correlates in terms of the survival of the patients. So we always stage cancer based on these three markers, and we call it TNM staging. The T stands for the extension of the tumor penetration. In prostate case, we have 4 T levels in. When you have a cancer cell but it's not penetrating any of the cells, it's called T1. It penetrates the prostate cells, will be T2, and it passes to the capsule, will be 3, and then invade the organ next to it, we call it T4. And I'll talk a little bit more about how this is important, especially for local diseases. I know the topic is for a metastatic disease, but this is an important thing in terms of determining the risk of the disease. The next is the end starts is the lymph nodes involvement. This is usually regional lymph node involvement. We do have N1 to N3, depending how many lymph nodes are involved. And then the last one is M stands with the distant metastasis of the disease. So we do use this kind of stagings for all cancers, and prostate is not an exception. The other thing that we use in terms of risk assessment for prostate cancer, I'm sure most of you are aware of it, as a Gleason score. This was first proposed in 1960s and revised about 12 years ago, 13 years ago. Basically, it takes, it's a pathologic measurement. And what they do, they take 2 samples from the prostate. Each would be scored based on their appearance under the microscope by the pathologist. If they're really well differentiated or they're close to the prostate cancer, the prostate normal cell, we call them well differentiated, we give them grade 1. And as become less and less differentiated or goes away from the normal prostate cells, the number goes up. And then we take two samples in and we added them, and then we give a total score of 10. And then the lowest the person can get is 2, the highest is going to be 10. Any results, any number above 7 is associated with an aggressive disease, like 8, 9, and 10 in general. So this is another thing that we incorporate in terms of the assessment for prostate cancer. So this is actually, it's a very wide topic, but in a nutshell, summarizing prostate cancer. If I do summarize it, will be this slide. So for stage 1 to stage 3 disease, we use these risk factors in terms of discussion how we treated it. Obviously, for stage 4 disease, we break it into 2 groups. We call it hormone-sensitive disease, or castration-resistant or hormone-insensitive disease. That's how we break it down. So let me go a little bit forward. This is in general what we approach it. I'm sure most of you in this room knows it. For stage 1 to stage 3 disease, the option the patient can have would be surgery, different type of radiations. In some cases also we watch these patients and then also use what we call androgen therapy, which I'm going to talk more in detail because it does have a big role in terms of treatment for stage 4 diseases. And also chemotherapy would have a role in metastatic disease. The only time I think we do use the watchful approach for a patient who has a very low risk disease and then their life expectancies happen to be less than 10 years. What I mean by that is if the patient has what we call a T score of 1 or 2, Gleason score less than 7, 2 to 6, and then the PSA at the diagnosis less than 10, and then the patient has a lot of medical comorbidities, and that time I think this approach would be also an option, watching and see. Whenever a patient diagnosed with cancer, as a cancer doctor, the first things, the patient under a lot of stresses, a lot of things come into their mind. And when we brought that topic of watching the patient, it's not a comfortable discussion. But most of the time, prostate cancer is a slow-growing disease. And then if the patient has all these good markers, watching is also an option. But the most important treatments, obviously, the local therapy will be radiation and surgery. And then we also use androgen therapy depending on high-risk factors. So let's get to the main topic of discussion today is the management of metastatic prostate cancer, specifically the management of hormone-sensitive prostate cancers. So let me just talk a little bit about how has the thing of metastatic prostate cancer has been going on lately. There's a couple of studies here that I looked at it. This is the first one, most recently. It's not a recent publication, but this is a study that looks at the incidence of metastatic prostate cancer from the year 2002 and 2013. They collected the data from almost 1,100 facilities in the United States of a patient diagnosis with prostate cancer. They specifically narrowed their cases from 2007 to 2013. And then when they look at the data, the number of patients with diagnosed and upfront metastatic diseases increased by 72%. This is especially even more significant in a patient between age 55 and 69. But the other interesting thing is that for patients with low or low risk prostate cancer, that is actually decreased by 37. When I looked at the paper, is there a reason behind it? Nobody can be able to describe why we have the low risk incidence are lower and the high risk are going up. But as we've been seeing it a little more and more that patients present with metastatic cancer. So the historical treatment of prostate cancer is based on androgen deprivation therapy. The idea came in 1940s when Dr. Charles Higgins, he's a urologist, did an orchiectomy and it showed that the prostate cancer is regressed. And then since then, we've been using androgen deprivation therapies for metastatic prostate cancer. Of note, Dr. Higgins is the only urologist that has awarded the Nobel Medicine Award as a urologist for these findings. So the other thing that the role of hormone in terms of regression cancer, we know from the turn of the last century in breast cancer, when the ovary is taken out, breast cancer also regressed. But it took about 40 years also to make that a leap to prostate cancer by Dr. Hagen's research. So what does hormone deprivation therapy mean? So this is the normal way of our hormone works. It's one of the roadmap is missing in this map, but I'll try to explain it. So we do make androgen in two different ways. One is through the testis. The second one is through the adrenal gland. There are two ways we make it in. But they all started what we call from the hypothalamus. The hypothalamus sends a hormone called LHRH, and then that in turn apply a signal to pituitary gland to send LH. The LH also plays a role on the testis to produce testosterone. On the other hand, the hypothalamus also sends a different signal called CHR to the pituitary, and the pituitary sends a hormone called ACTH to the adrenal gland, and then you produce adrenal androgen. So we produce it in two different places. So the role of this androgen deprivation therapy is to shut down this path and also to shut down this path. So to starve the prostate cancer, the hormone that it needs to grow up. The other alternative is orchiectomy, taking out the testis. So these are the number of androgen therapies we have. The traditional or the first generation androgen therapy. The first one we call it JNR agonist. This actually break the testis to pituitary axis, and if we can go back and break this axis, shut down this one. So that's the way Lupron works. And Lupron is a subcutaneous injection. We give it every 3 to 6 months for our patient. The other one we use is androgen receptor blockers. This does not shut down the production of testosterone, but it does shut down the effect of the testosterone in our bodies, including the prostate. So the best medication we use is Casodox. It's an oral agent. It's been available in the market for a long, long time. So those are the two first generation hormone deprivation therapies we use. And then the second generations that comes back is abiraterone or Zytiga, and also Xtandi. This also works slightly different, especially this one. The Zytiga is actually, it works by shutting down this path. It does shut down the production of the androgen from the adrenal gland. The adrenal gland not only produces androgen, it also produces steroids. So this medication given along with the steroids, because that's also shut down. And so whenever a patient gets Zytiga, also gets steroids. Xtandi works kind of similar to Casodox. It just blocks the effect of the hormone on the prostate cells or the prostate cancer cells. So we've talked about in terms of what kind of options we have, how this has been a historic treatment that we use since the 1940s, and how are we doing with this medications. These are the two studies that looked at how long are the people surviving with only androgen therapies. This is a publication in the Urology Journal. Shows a patient treated with only androgen deprivation therapy and metastatic prostate cancer, they live about 30 to 33 months on average. So that is about a little bit more than 2 years. And then this is also a second paper that was published in Cancer Journal. This is a California study. So they looked at all the people diagnosed with metastatic prostate cancer in California between 1988 and 2009. And then they've noticed that they have not seen any difference in terms of their survival over the 20 years. So we kind of at that time, maximize the benefit of androgen deprivation therapy when it comes to managing these patients. So always, as a clinician, as a researcher, so what can we do better to improve these things? So at the beginning of 2003, there are a couple of studies done for a patient who already failed androgen deprivation therapy that given a chemotherapy, specifically docetaxel, is found out that they can get a little bit of overall survival benefit. So what the researchers did was they took the chemotherapy and added to the androgen deprivation therapy upfront. Don't wait until the disease progresses to give a chemotherapy. So there are two studies that looked at this. They both come in around 2015, 2014. One called Charter Clinical Trial. This was done here in the United States and completed in 2015 and published at the beginning of 2016. The second one is the Stampede Clinical Trial. This is a United Kingdom trial. This is a continuous multi-phase trial. But they both looked at compare androgen deprivation therapy by itself versus androgen deprivation therapy plus chemotherapy, specifically docetaxel with 6 cycles. The inclusion criteria is metastatic disease with hormone sensitive, no prior treatments. Their goal is overall survival. The second goal is to see how much we delayed the PSC progression, or make the castration-resistant disease, or time progression for clinical, or time to clinical progression, including like the disease is spread needed by CAT scan and things like that, on top of PSAs. So that was the criteria for the study. This is just a breakdown of the studies, and just to give you an idea how they break it down. So you have here the chemotherapy group with hormonal therapy included. This is only hormonal therapy. If you can see, they almost break down into equal groups, all the way down in terms of the race background, the age background, their performance status, the disease is what we call a low or high burden disease, and even the Gleason scores. So it was a pretty good study. So what is the result? The result of this Charter trial is it shows those people who received the chemotherapy and the hormonal therapy, they lived about 57 months on average, compared to only the chemotherapy, the hormonal therapy, which is 44 months. But when they break the disease into high volume and low volume disease, you can even see in those patients with a high volume disease, the overall survival is about 49 months. This is about 50% of the patients versus 32 months. If you remember earlier, when we looked at those two studies, and people live about 30 to 33 months with this disease. So we have a jump here about 15 months by adding this chemotherapy with 6 cycles in. For us as a medical oncologist, this is a big thing. When a patient gets to the point of stage 4 disease, our goal is 2 things, to buy time and to give a good quality of life for a patient. If we can give a good quality of a patient for 15 months, we did our jobs. So this is a big, big number. So this has changed in terms of how we approach a prostate cancer that has presented with metastatic disease. The second, this is just a graph showing the difference between the 2 groups in terms of the survival. This is overall survival in both groups. This is in those patients who has a very high volume disease. And then this is the patient who have a very low volume disease. This is the also the hazard ratios, and showing adding the chemotherapy helps in all groups of these patients. And then in terms of the secondary point, the PSA level less than 0.2, there are 127 patients compared to only 77 patients. And if you use the same things, castration-resistant prostate cancer, or basically, the disease is advancing, on average it takes 20 months to do it compared to 11 months with adding the chemotherapy. So this comes with, everything comes always a caveat in it. So this comes with the side effects, obviously. Chemotherapy gives you side effects. So the most common side effect would be, in this situation, would be fatigue, and then what we call febrile neutropenia can happen. And so basically, during the treatment, which usually 6 cycles, and it's about, depending, give and take 4 or 5 months, you can experience those things and compared to getting only hormonal therapy. But at the expense of that, a patient in general saves about 15 months of life. And so the conclusion of the study is basically, adding the 6 cycles of chemotherapy significantly increase overall survival, increases the rate of PSA increase intervals, and also increases the time to develop castration-resistant disease. The second study that we've talked about at the beginning is the Stampede clinical trial. This is a European, mainly United Kingdom trial. It has 4 arms on this study. They looked what we call androgen deprivation therapy, and they added a medication called Zometa, which is a medication we give for a patient who have a bone disease. But this medication knows to prevent like bone fracture, pain, and things like that for those people who have bone. So they added this study, and then compared also the same thing the other study did, the chemotherapy and then the androgen deprivation therapy, and then the last they add all 3 things together. The average person on the study group is age of 65. Here they include not only a metastatic cancer, but they included a disease that has not spread yet, but has a high risk factor. So if you guys remember, we talked earlier, the high risk factor would be high PSA level greater than 20, and a T3 or T4 level, and then also a Gleason score greater than 7. So those patients were included in this study. So there are actually about close to 40% of the patients are local disease with high features in it. So the study was started from 2005 and 2013. They followed this patient for 42 months, and their main goal is to look, the overall survival. And this was published in August 2016. So let's look at, this is just a breakdown of the study. It's a little bit complicated, but as I summarize it, this is the standard of care. They added Zometa, they added docetaxel or the chemotherapy, and then they added all 3 things together. So those are the hazard ratios. Actually, I can show you a little bit on this one. This is the result. The median overall survival in this study said 71 months for those people who only got the androgen deprivation therapy. For those patients who got the chemotherapy, it's 81 months, and then those patients who got Zometa was 76 months, or added Zometa to it. But when they break it down into only metastatic disease, here it shows 45 months versus 60 months. Remember, this includes a high volume versus low volume disease. But you can definitely see the significant improvements from the disease, from 45 months to 60 months, adding that chemotherapy upfront. So this is the graph showing those findings. The left is progression-free survival, this is overall survival, this is the main one. When we add a chemotherapy, see the difference. Right here is just the hormonal therapy, but when right in the red one is when you add the chemotherapy, see the difference in terms of overall survival. So both these studies showed that a significant improvement in overall survival. I'm sorry, here we go. So this actually changed in terms of how we approach these diseases. So this is one of the main clinical investigators, summarizing this thing. It says docetaxel should be considered for routine practice in suitable men newly diagnosed metastatic disease. It should be considered for selected men with a very high risk factors or very high risk non-metastatic disease, because it prolongs life and it also prolongs failure-free survival.
Excuse me, can you go back to the Kaplan-Meier curves?
Sure.
Because it seemed to show that for men, on the left is people who already have metastatic disease, on the right is people who don't, right? These are the high-risk patients, no?
No, this is overall everybody. So the left side shows event-free survival. This one shows overall survival. This specific Kaplan-Meier graph shows the combinations of hormone, is very small things to see. It's hormone therapy by itself. They do use two different Kaplan-Meier survival for each compared to the chemotherapy.
So they bundled both metastatic disease and high-risk disease in
Correct.
this curve?
On this curve, they bundled them, but let me see. Right here, the actual numbers when they break it down. You see, for one subset analysis specifically for only metastatic disease, you see the overall survival is 45 versus 60. But when they bundled it, you're right, 71 versus 81 months.
So it's not clear from this that it really benefits men who have local high-risk disease.
It does, let me actually see if I can put it in. So this is right here. Right here, this is, let me see, yeah. So this is just, yeah, the general, they just bundled it. They just bundled this one in. But when you break it down, I don't have here, but it does also shows a benefit for a local disease who have a very high risk factors. When we say that, it would be like those three things we talked about. PSA of 9 and 10, 8 also included, and then not PSA, decent score, 8, 9, and 10, PSA greater than 20, and then a T3 and T4 lesions. So I'm sorry, I missed that specific slide, but it does definitely help those patients. Obviously, when you offer it, because we do have a good result with hormonal therapy for those patients only, you can only offer patients who are completely fit to take the chemotherapy, because we say those patients have high risk for the side effects. So you won't give it to anybody, but you just have to select the patient, high risk factor and good performance status. So we came back to the same thing that we talked about it. We don't give this chemotherapy for everybody because it has side effects. Especially as we see this, this is a disease of a people who's in their 60s and the 70s, and a patient have a lot of medical comorbidity they develop as we age. So not everybody tolerates the chemotherapy despite this good results showing a benefits. So what the next thing that we went through to do is like, what can we do to improve for those patients who can't get this chemotherapy? So the next thing that we wanted is the second generation androgen deprivation therapy. If you guys remember earlier, we talked about a couple of the second generation therapies, and one is abiraterone or Zytiga, and then the other one is Xtandi. So do this hormonal therapy have any roles in upfront settings? Because we've always in the past used it if a patient failed the upfront hormonal therapy, which is the Casodox and then the Lupron shots. So there are two studies that looked at this. The first one is it's called Latitude Clinical Trial. The second one is the same things that we did in the Stampede Clinical Trial, but the continuation of it. This only looks metastatic disease. This again included high-risk features disease. So let's start with the second one first. The Stampede Clinical Trials, they compare androgen deprivation therapy and with abiraterone and then androgen deprivation therapy. Basically what they say, they exchange the docetaxel or the chemotherapy to this medication. You remember this is a medication that shuts down the androgen production on the adrenal gland. So they did put 95% of these patients are newly diagnosed patients. Metastatic disease about half of them, and local diseases about half of them. They did even add like about 20% of the patients that are node positive, and then 28% of node negative disease. About 1,900 patients enrolled in from 2011 to 2014, and then they're been followed for 40 months, and then the median age is 67. So this is the actual results of that study. 3-year overall survival for the patient who received the abiraterone on top of the standard therapies. About 83% of those patients are alive and kicking in, and while 76% of those patients only alive if they are getting the standard hormonal therapy. And the study groups in 184 patients died from this disease, compared to 262 people only for the androgen deprivation therapy, which is the standard androgen deprivation therapy. This is basically event-free survival. Basically, what they mean is like the disease is not progressing. So 75% of the patients are not progressed in the study groups, while only 45% of them are not progressed on the and then the clinical trial groups. And the same thing with skeletal freeze. This is basically talking about a bone disease, fracture, pain related to bone. So abiraterone is lower the disease failure rate by 70 to 71% when we give this patient upfront in terms of treatment. Going back to the earlier thing, when we recommend treatment for any cancer, we use the NCCN guideline, the National Cancer Network guidelines. So right now, docetaxel is involved as a recommended things for a patient who has advanced disease or metastatic disease to be enrolled in or to be considered. This has not been enrolled yet, but this is probably going to change because of this data. And then this is the graph also, the Kaplan-Meier, and then this on the left side, this is again event-free survival. This is overall survival. This is event-free survival. The overall survival in all groups here, and a patient with metastatic disease and a patient with non-metastatic disease. So in this specific one, to answer your earlier question, we didn't see a huge difference in a patient who doesn't have metastatic disease, but you can clearly see the difference in metastatic disease. And then this is event-free comparison between those two groups, and you can see in all groups, whether it's an all group, metastatic disease or local disease, this will benefit them. And then this is also the hazard ratio showing the benefit in pretty much in all groups. This is one of the graphs. They say, how long does it take the patient to fail their treatment and needed an extra treatment? You remember this study is a multi-phase study. The US, Great Britain study continues to evaluate diseases as they go through them. So they have even, here is the hormone therapy. This is the chemotherapy, docetaxel we talked about. This is right here is Zytiga, which we haven't talked about, but this is one of the also subset groups outside of this clinical trial they looked at. And then this is the Zytiga. You can see in both graphs here and there, the Zytiga group are the one that are the least likely to need treatments or require treatments compared to the other groups. So it does really help the patients avoid the disease progression or getting another treatment for a longer time compared to for the 4 other options that we have right here. And this is the side effect of the Zytiga. The main side effect, I know you guys can't see it, is it can affect the liver functions. So we have to monitor the liver function very closely. A couple times I have stopped the medications for my patients because they develop a liver abnormality. You can also see hypertension and fatigue also can happen. But this is much, much better tolerated compared to chemotherapy. And we still give it as a second line if they failed it, but I think this has to come to the front line for this patient based on this data set. So this is the same thing, so it does help because we give this thing with the steroids because it shuts the steroid production from the adrenal gland. It's significantly higher overall survival and event-free survival compared to hormone deprivation therapy by itself. The other study is the Latitude study. This is actually a multinational studies. 34 countries participated. This does the same things. And they compare abiraterone plus androgen deprivation therapy versus androgen deprivation therapy. Here they only included metastatic disease. And then their goal is overall survival versus what we call progression-free survival. And again, here, almost 2,000 people involved in this, almost 1,200 people involved in the study. They followed for 30 months. And the median overall survival at 30 months, with statistics checking, has not reached for the people who received abiraterone. But the statistics curve shows that about 34 months would be only for the androgen deprivation therapy. And then for those people who have radiographic-free evidence, there's no disease progression on the CAT scan, you can see 33 months versus 14 months for the study group set. It also improves the PSA progression rates, skeletal events, and pain progressions if the patient is exposed to the abiraterone afterwards. So this is a graph, the Kaplan-Meier graphs showing right here the overall survival. You can see the abiraterone groups has not reached or has not reached the 50%, while the placebo or the hormonal therapy hit the 50% about 34 months. And then this is in terms of radiographic-free survival. It hit 50% close to 33 months versus 14 months. So you see a significant difference in those two groups. This is just the second line or the second goal. This is pain progression. This is PSA progression. This is also bone-free events and fracture, bone pain, and things like that. In all 3 groups, you can see the abiraterone does much better than the standard hormone therapies. This is just summarizing the PSA progressions in terms of event-free survivals and things like that. Just confirming those points. You can see the p-values complete. When the p-value is less than 0.05, that's what it says this is significant. And then this is really lower than 0.05. So in all groups, and this helps these patients with relatively minimal side effects compared to chemotherapy. The main side effects, again, is like liver function abnormality right here. It does occasionally also increases the blood glucose for those patients, especially who has diabetes and hypertension. So the conclusion is, among men with metastatic prostate cancer, androgen deprivation therapy plus the abiraterone is associated with significantly higher rate of overall survival and failure-free survival compared to androgen deprivation therapy. So we started, from the 1940s, using orchiectomy to treat prostate cancer. And then after that, we got to the first line of therapies with the Casodox and Luprons and things like that. And then at the beginning of the early 2000s, also we started adding docetaxel to treat it. Obviously, docetaxel has impairment because it's a chemotherapy side effect. Now, with adding the abiraterone, we can almost get the result of the docetaxel without the side effects, and at least from these two studies. But NCCN has not updated this yet, but I suspect this is going to be the next thing to be updated in terms of recommendation for the treatment. So where do we go from here? Obviously, we can continue what we're doing right now. I think there are clinical trials out there, just checking the androgen deprivation therapy plus chemo, and androgen deprivation plus abiraterone, or also androgen deprivation plus abiraterone plus docetaxel. That's currently going in. We see it's like this: 1 is good and 2 is better. If 2 is better, 3 is even better. And, so it's out there with the results yet to come. The other things that I'm sure most of you are aware of it, the major improvement in stage 4 disease in the past 10, 15 years is immune therapy for other cancers. And I'm sure you listen in the TV, Keytruda, and Opdivo, and things like that. Those are immune therapies, and what they do is, we have our own immune system that helps us, fight infections. And that immune therapy also has a break in it. If there is no break in it, that immune therapy attack our own bodies. So what we found lately is like if we take that break a little bit, the immune therapy awakes and thinks the cancer cells is an enemy and starts attacking it. This has worked really well in certain cancer, melanoma, skin cancer, to a certain extent in kidney cancer and lung cancer. It has been working. There's a trials that have been done. Does it work on prostate cancer? Unfortunately, the most important, we call anti-PD-L1 therapy has not been working for prostate cancer at all. But what they were trying to do lately is like they apply 2 different breaks in, to take 2 different breaks in from the immune therapy, which we call anti-CTLA4, anti-PD-L1, see if that combination can help. Those are some of the clinical trials that are going on right now in terms of the immune therapies. So the traditional things that we're doing is continuing what we started before, adding chemotherapy and aggressive hormonal therapy versus immune therapy. Those are the things that we know right now. So eventually, unfortunately, no matter what we did, the cancer cell gets smarter and smarter, and it keeps everything that we do. So what are the things that we do if that happening? What's more important is, as a medical oncologist, is taking care of patients' symptoms, palliating their symptoms. And this is very important for us because as healthcare providers, we do 4 things. The first thing that we do is to try to prevent things before they develop. That's why we do colonoscopies, mammograms, to a certain extent PSAs, and things like that. Those are prevention things we do. The second thing we do is to try to cure things. That's why we do surgery, radiation for prostate cancer, give antibiotics for pneumonia, and then the surgeons going out and cutting out the infected part of our body. Those are the the things that we do to cure it. The third phase of things that we do is to try to control the things. If a patient has poorly controlled diabetes, we try to control it. And if you have high blood pressure, heart failure, we can control it. Even the cancer setting, the patient has stage 4 disease, we give chemotherapy, immune therapy to control it. The last thing that we do, if we cannot control the things in this situation, we try to palliate the patients, give a good quality of life for the patients, manage their symptoms. So I wanted to do a couple things on this, and I'll finish the talk and open for discussions. So in prostate cancer, for that matter, in any other cancer, palliation symptoms is very important because it improves the quality of life and avoids morbidity and mortality. So those are really important things. The most important thing in prostate cancer is prevention of bone events. Because prostate cancer is really likely to go to the bone, and when it goes there, it causes a lot of pain, fractures. That's morbidity and mortality. So we do have different agents to help a bone events in it. The most important things are here. What is called bisphosphonate? If you guys remember in one of the studies, and they involved these things, and because this clearly shows prevention of the bone disease progressions. So this is a bisphosphonate, and it's been used for a long time to treat osteoporosis. It can be given in any stage of the disease. It's in Europe, and here in the States, usually set aside for castration-resistant disease. The limit with these things is it does, it's cleared by the kidney. So patients have kidney disease and things like that, we're kind of limited to give it. But if a good functioning kidney, we can give it to them. The only major side effects, or the two side effects we look at, is one is rare, which is osteonecrosis of the jaw. So the patients, before they start, we like them to see a dentist. And then also it kind of decreases your calcium level. So we check the calcium level every time we treat it. The other one is called Xgeva. This is a more recent one. It works slightly different. And then you don't need to have a perfect kidney to take it. It does do the same job as Zomeda, maybe slightly better. But it does have a slightly more side effect of osteonecrosis of the jaw. The same thing with Zomeda, but slightly more. This is a lot expensive than Zomeda, so a lot of times insurance companies fight with us, but I think patients have a kidney issues and things like that, we prefer to give these things. The last one is called radium-223. This is available only for castration-resistant disease. It also shows, I'll show you the data, it can give a patient a survival benefit. You won't get a survival benefit in these two medications, other than preventing a bone event. So let me look at the study quickly. This is a clinical study that evaluated the radium-23. So radium-23 is alpha emitter and selectively target the bone metastasis by alpha particles. So they compared this versus supportive care in a patient with symptomatic bone disease and castration-resistant disease. This is a patient who progressed after they treated anti-hormone therapy. They looked overall survival, skeletal events, and a PSA evaluation. So you can see in the Kaplan-Meier graph right here, those patients who developed got a radium-23. They lived about 15 months on average compared to 11 months on those patients who hasn't got these things in. So it does help patients living better, and also at the same time it helps prevent a skeletal events. You can see it's like about 15 months before skeletal events happening. Right here is about 10 months on the patient who have now received these things. So we do use those three things in the Zomeda, the Xgeva, and then this to help for the bone disease. So those are in terms of policy things we do for prostate cancer. This is just the hazard ratio for all groups in. Radium-23 much better than placebo or supportive care. So with that, I'll finish my talks and open for questions. Yes.
You had said, or one of the early slides said,
Sure.
all of this data is based on people who have not had any prior treatments. So is there any information on people, men who have had prostate removed or radiation or anything like that?
In both studies, actually I would correct that. A few patients have treatment before.
Okay.
Few patients.
It said no prior treatments on one of the
Yeah.
slides.
So in general, let me see if I can find it.
It's very early.
It's very early. So,
lights back down, you want the lights lower again? I'm sorry.
I'm sorry.
You want the lights turned down, or you can refer to the slide, we'll turn it back down.
So it might not show. It's almost, if you pick like 4 or 5 patients they put in those situations, they were previously treated. It could be radiation, it could be surgery, but not hormone therapy. Like for local, we talk about for the local diseases. You remember one of the study involves a local disease was high risk.
So would you expect the results would be the same for men who had no prior treatment or men who have had prior treatment?
So the prior treatment is not hormonal therapy.
Right, I understand, that's what I'm saying, but all this study is based on men that said no prior treatment.
Correct.
You're saying 4 or 5, that's
Yeah.
not very many, so
Yeah.
that doesn't really.
I would say the result is the same. That's why they recommended for high-risk patient to be given it. Because the disease once spread, whether you had radiation surgery before or not, it behaves almost the same. Once it spreads out of the get-go, it's high-risk and so it spreads in an outside stage 4 disease. So I would say the same.
And so when you say metastasize, has it actually been found, or the PSA is climbing but it's not known where it's at?
No, this is metastasizing.
Well, I understand, yeah, okay. So,
Yeah.
so
No.
it's actually been found in a
Correct.
scan
Correct.
someplace else. You
Correct.
know exactly where it's
Yeah,
at.
it's not based on like high PSA by itself.
Okay.
So usually it correlates, but it's not by PSA only. Yes. radiographic evidence of the disease.
Most of your numbers talk about the average age of 65 and the deaths. Would it be any different if the folks are 75 or 80? Would you behave differently?
So it would be different in terms of the patient tolerating the treatment, especially for the chemotherapy. You know, as we get older, our chance to tolerate it gets a little bit harder. But in terms of the diseases, there are few things determine how patients respond for treatment. Obviously, the patient performance status is one thing. The second thing is the burden of the disease. Can be another thing. The third thing is, we always struggle is the biology of the disease. You can diagnose 10 people with Gleason score of 8, local disease. Their outcome can be completely different because the biology of the disease is completely different. Certain mutation happen in certain patients, certain mutation doesn't happen, and so that would determine the pace of the disease. So one guy, completely doing fine, another guy's like, the disease spreads and relentlessly. Hopefully, most of the time, I think prostate cancer grows slowly. For an overwhelming patients, and the pace of the disease is slow. But I've seen a guy who diagnosed with stage 4 disease, and treated him in hormonal therapy with, put docetaxels in. The disease responds for a while, but it just keeps coming. It beats all the average of these people. So certain biology are so fast. I can't explain, but the performance, the burden of the disease, and the biology plays a role.
Could you stand up in front?
Yes. Yes.
Us old people get stiff necks.
One question I have.
Yes.
A lot of this is, what about a cancer that does not respond to the hormone?
The question, you talk about metastatic setting,
Right,
no
right.
treatment before. They all kind of respond. The question is how long that response lasts.
Okay.
It comes back to the biology of the disease. A lot of times they respond really nice, but numbers usually don't lie. The average person respond about 30 months. And if you see that the beginnings and all the way back to we started the chemotherapy. There's certain people last like 50 months, and then at the same time on the other side patient develop only for 12 months. But they all respond. It's just a question of how long that lasts is the big question. Yes, sir.
I was trying to keep up, but can you tell me if my conclusion is, if I understood well, that in general, people with prostate cancer that goes outside the gland and metastasizes, from what you were saying and the numbers I was trying to understand,
Sure.
it looks like they live 2 to 6 years. Did I conclude right?
It depends what treatment they get exposed to. The standard therapy is an average, they live about 33, 34 months with only hormonal therapy. But if the patient is fit enough to take docetaxel, that number it gets closer to 50 months. But not a lot of people can afford tolerate to take that thing. But if you can take that, you would buy 50, 60, 70 months an average. And that results about the same also on abiraterone. And if I, God forbid, have a stage 4 disease or prostate cancer today, I will take androgen deprivation therapy with abiraterone upfront. Because that number is about the same as the chemotherapy. But the second option is to take the docetaxel. The only problem is since NCCN does not approve it right now, I don't know the insurance company will give you abiraterone upfront, but you would get the chemo if you can tolerate it. I hope that answers your question.
Is this all about stage 4?
Correct. This is stage 4. Yes.
So for the mortality statistics, okay, how many of those men died from prostate cancer versus dying from, I don't know,
Other stuff.
other stuff?
So, it's, I didn't have the detail of everything, but it seems like it's mainly prostate related. Could they have like a prostate bone events in, they have fracture or blood clot, and the complication of that lead to that is possible. But this is mainly prostate related. It's not like heart failure or diabetes and things like that.
And the reason behind the question is that because of the side effects, so the sex at the ADT, they all have side effects, right? I mean, there's a reason for having testosterone, it's not just for sex, right? It's
Yeah.
also important for all kinds of other bodily functions,
Yes.
heart, lungs, I don't know, brain, and so forth.
Everything, it's just, it makes you know who you are.
So when you have to consider treatment, do you also consider the impact of these side effects?
Yes, definitely. Most of the time, I think, people start with only, historically with Lupron shock, unless you have a very high disease burden. If you do have a disease burden, they add the Quesadox on it. Historically, I'll talk about it. But it comes to, the thing that we always face every day when we treat cancer patients, the risk and the benefit. If we can give your patients these things in, you always get this side effects in. And what is, how you try to balance that thing every day. Obviously, hormonal therapy has those things that you told. And then if you have chemotherapy on top of that, we talked about like febrile neutropenia, fatigues and things like that. So you can add that on top of that. But on the other side, then, you have 15 months you buy for if a patient, tolerated enough to do it. So everything, even, and I think I always say, even aspirin has side effects.
If
Go
I
ahead.
may, let me just pursue that one
Yeah.
step further. Okay, unfortunately, for that patient who dies after 30 months, who was on whatever, ADT plus a Secretel or whatever, what would have happened if you hadn't given them? In other words, you can't repeat the experiment, right? Every person is different.
Correct.
Um,
So that's a very good question, actually. So if we get it sequential, we get only hormonal therapy followed by chemotherapy versus we gave all together. There's a big difference in terms of survival. So what happened? Why the survival difference? Because the drugs are the same. You gave them sequentially versus gave them upfront in. They've looked at those, they had a discussion about that. What they felt is like during the treatment of hormonal therapy, the cancer cell continues to mutate. By the time you get to the chemotherapy may not as effective as it would have been upfront before they start mutating. So that's the conclusion in terms of how they approached it. But still have other chemotherapy that you can give even after you give everything together. But the benefit would be smaller. You get the upfront benefit right there. You got 17 months benefit upfront, and then at the back tail, if you still have, you can get treatment, but it might not be as effective as original.
And let me follow with one more
Sure.
thing. If you look at any of these curves, so you have the median, the 50 percentile, and those that did not survive, or whatever the criterion is, those that were less than 50, had
Before
less than
50,
50%,
yeah.
those that had greater.
After.
Do we know anything about why those particular individuals did not last as long as the others? Have there been any studies in that?
Not specifically, but I'm not looking at all the other cancers. And this is pretty common. When a patient comes with stage 4 lung cancer, for me it's like, doc, tell me the honest truth. How long I'm going to live. We could quote the statistics. It's like 50% of these patients that come from at this time, so, the other 50% continue to live. There is no fast data to say it's like how do we determine, but those three things still play the same role: the patient functional status, the burden of the disease, and the biology of disease. Let's say if a patient comes with stage 4 prostate cancer that is already spread to the liver and other organs. And there's another person who comes with stage 4 lung cancer, stage 4 prostate cancer only in the bones, few bones. So if you treat those patients exactly the same approach, then it's most likely the patient who has a very high burden disease succumb from the disease sooner. If you add the functional status and other medical comorbidity, those can play a little more. And then those patients have also good social support systems, and they can follow their doctors and take the medication appropriately, has less burden. They tend to be in the latter part of the tail, but that cannot guarantee. But that's in general what happens. But I don't think anybody specifically say this person falls in the 50% before or after without saying those things.
So, to me, that's one of the concerns I have. You know, we talked today about precision medicine, about, you know, targeting therapy to the patient. It seems like the urological community in general seems to rely on these very large studies, whether they're retrospective or actually
Prospective.
prospective, like these guys. And they don't seem, okay, so other factors don't seem to play into these. So, you know, some people can have a lot of, perhaps their immune system is not functioning as well, perhaps, I don't know, but maybe they're depressed, maybe they have high you know, maybe perhaps a diabetic, or, you know, have high insulin levels. I don't know, all kinds of factors that may contribute to disease progression.
Yes.
But that's not built into any of these studies, is it?
That's the art of the, you know, the practice. You know, you would not learn that by looking at the graph. You learn that by seeing the patient. The patient coming in front of you. What kind of support system does the patient? They see the patient, you know, lives by himself, fighting this thing by himself, compared to the patient has like 5 people supporting and bringing food in. So that makes a difference. The same thing as you say, patient have heart failure, and you can't give him a lot of fluids. Versus the patient is like, you know, right before the diagnosis is, you know, a marathon run. That all plays into it. That is an art. I think. I don't think I would put a number in it. That's why I evaluate the patient. There are a couple of things that we can do. For example, for multiple myeloma, there's a bunch of studies we do. No bunch of studies we do. Bunch of question you answer to see how fit you are, because one of the treatment is a bone marrow transplant. Not everybody will be offered a bone marrow transplant. So you do screen those patients, see if they have all these things, and you have heart failure. Can you walk in, you know, a mile without shortness of breathing, and things like that. And you can come back with that. The other things also is like the functional status. It's a kind of subjective thing. It's not an objective, but you know, you evaluate the patients, how much they function at all. You know, they can cook, clean, take shower, walk, and take care of themselves, versus relying on the other person. So those all contribute these things. And that's why I was talking about one of the things for the disease, other than the biology and the burden, is the patient's and performance status. Got a question there?
Yeah, okay, I've had chemo, I had a prostate removal,
Okay.
and so now I'm taking Lupron.
Okay.
They told me I need to take that for 3 years. I'm a year and a half in now. So I got another year and a half. So my question to you, if you're familiar with it, and it's been said here in the group, that once I'm done with my Lupron shots, and I've been on, say I've been on 3 years, now when I'm done, is it true that as long as you've been on it, that's how long it takes to get out your system?
That's a pharmacological question. So you get it every 3 months, every 6 months?
Every 3 months. At first when I started, it was once every 6 months.
Okay.
But now I do every 3 months after
It usually clears out, after 3 months, I would say, because that's why we have to give you every 3 months. It might have, some effects after that, but it does usually last, what you were saying. If it was 3 months, 3 months. If it's 6 months, it's 6 months.
Okay.
You did have, if you don't mind me asking, it's just a local disease that you have.
I had prostate cancer.
I know, it hasn't spread anywhere else, right?
No.
But you got chemotherapy?
Yeah, I had
The
for 6 months.
Okay. So you got what we were talking about earlier, so for high risk things, even up front, even for a local disease, it has a benefit. I didn't have the slide to show to you.
But before that, I had the seed implant,
Okay.
the radiation seed implant, and it didn't work.
I see.
And,
Okay.
right.
You have a local failure.
Right.
Okay.
And it went and did the
Okay.
robotic surgery.
So that's different. Okay.
Yes.
Okay.
Thank you.
Oh, you're welcome. Yes, sir.
There's a lot of interest. You may have commented on this indirectly, but when you get to these advanced stages, can lifestyle changes, even if pretty drastic ones, do they have any impact, or is it too late for that?
So if you have an advanced disease, can that affect your lifestyle?
Something, exercise, diet, lifestyle, low stress, good sleep, all of that stuff. Does that have any impact anymore? Or is it?
Oh, to have the disease, you mean, to fight the disease?
No, once you have it,
Yeah,
and if you're in the category you're speaking of here in this
yeah,
presentation,
yeah.
if you're one of those victims, I'll call it, and if you make drastic lifestyle changes, in addition to what you're doing here, is there any evidence that it really helps, or is it too late for that to have any impact at all?
I mean, I can't point out a number for you, but, you know, people who have a positive attitude, say, active and keep their lifestyles, and they tend to do better. That's one of the things that we talk about, you know, who's in the tail, who's in the front end. In general, you know, people have a positive attitudes and good support systems and continue to live life to the fullest. I've seen them tend to be in the latter part of the tail. But if I have a number to share you, no, I don't have a number to share you. Other questions? Then? Yes.
Well, I have a different kind of question. Since you're from Africa, Ethiopia, I was looking at heat maps. There are heat maps showing the rate
Bottom up, I'm sorry?
heat maps of the world, actually of the globe,
Sure.
showing the incidence of mortality from prostate cancer. And surprisingly, according to this map that I saw, the highest rate of mortality seems to be in equatorial Africa, right along this band from, from the Atlantic all the way across
To the Indian Ocean.
Indian
So it comes back to the thing we discussed earlier in terms of the incidence of the disease. You know, people who have an African American and African backgrounds tends to have high incidence of this disease. For general population, this is, as we said, it's like 1 in 9 patients, or 1 in 9 males would get it in general population, but in African American or African populations, there's a 70% increase compared to the white populations. And so that would put a big close to like maybe 15, 17, maybe even 20% of us, of the African heritage or African Americans have a chance, getting longer to have this disease. Could that be environment? I don't know, but it's probably a little bit of genetics, as we say, that it can play. Genetics is usually 2 types, and one is what we call somatic mutation, and the other one is the non-somatic mutations or germline mutations. This is something that you inherit from your parents. That's the one we talk about, BRCA1, BRCA2, and things like that. But a lot of times in a lot of diseases, like caused by somatic mutation, this mutation happened after we were born, and we haven't inherited from our parents. So, you see kids getting, leukemia. They didn't do anything. So they didn't smoke, they didn't drink, they just lived very small times. And so, a lot of times, a lot of cancer happen because of the somatic mutation. And the same thing is true prostate cancer. There's a lot of somatic mutation we don't know causes this disease. There are few we know about, non-somatics or germline mutation like the BRCA1, BRCA2, things like that. It could be a combination of environments, genetics, and things like that.
Okay. Could also be related to how soon the disease is diagnosed, because here in America, everybody gets a PSA test, when they hit 50 or whatever, so I'm not sure what it's like in those other countries.
There's 2 points. I think they're the main issue. Now it's becoming people have a little more access, especially in the big cities, and, the middle class and tends to get, this might not be as, advanced medical care as here, but they can start getting a little more. But the main issue there always is infectious disease. So that's a battle, because that's the thing that kills, a huge number of patients because they don't have a good access to it. But as, people try to develop their countries, that's going to be an issue.
We haven't heard a lot from TriHealth over the years. How many urologists are in the TriHealth family now? I mean, there's like you have
So
500 physicians or something like that. So what are you doing with surgery and radiation through TriHealth, or your joint venture with the urology group, or how did your company operate?
Correct. So we do have a joint venture with the urology groups. We work with the urology groups, but we do have our own radiology department, radiation treatments also. So it would be nice if one of our radiologists come and talk to you guys too. But in terms of surgery, we work with urology groups.
So if I went to my primary care doctor and she recommended a PSA, they would go to the urology group, is that what you're saying?
If the PSA becomes abnormal, yes,
They refer you right down to the urology group?
Correct.
That's a joint
correct,
venture then?
yeah.
Okay.
It's a joint venture. So we do for all cancers, for kidney cancer, bladder cancers, testicular cancers, they do all those things for us. But we work with them in tandem.
Mhm.
Yes, ma'am.
You had a slide that, I think it said something like there's a 90-something% increase in prostate cancer.
In older populations,
In
yeah.
older
That's
populations.
specific.
Are there populations, has there been any comparison, is that American men?
Yes, it's
So are
completely
there
obvious.
populations in the world where there's low incidences of prostate cancer, and are they being studied for diet or lifestyle or anything?
Not sure if I have those numbers, I don't have the number definitely to tell you. It's like compared to the US incidence versus non-European. Obviously, the European incidence is similar to because one of the studies done in the United States.
Yeah.
But outside of Europe, I'm not sure if I can give you. And the second study, the latitude study that shows the average role,
Yeah.
has 34 countries. When I looked at it, some of them are Latin America, but it doesn't include Far East and Africa.
I'm thinking Asian countries where they eat more fish and
Yeah.
don't eat all the garbage that we eat in the States. No
I don't have the
studies.
numbers with that, yes. I mean, I can tell you as a cancer doctor, the Asian populations tends to have less cancer except two types of cancer. One is in Japan specifically gastric cancer, and the rest of Southeast Asia is like hepatitis B and C are common, so they tend to have what we call hepatocellular cancer or cancer of the liver. But other than that, I think their overall cancer incidence is lower than the Western societies. Yes, sir.
I have a question. In diseases that haven't metastasized yet, if you're going to receive radiation, they like to give you a Lupron shot before they start the radiation. And at about the 2-month point, start the radiation, and then give you one more Lupron shot at the end of 3 months. Is there any advantage to extending that to 3 or 4?
For local disease, containing the prostate. I don't know if there's any benefits, and I think we do the same things for certain cancers like rectal cancer, colon cancer. The idea is like to give you something to shrink it as much as we can, so they can do what we call a definitive treatment. Could be radiation, could be surgery. But after that, I don't believe there's a data to support it. But before that, I think it helps the radiation that you receive to have a maximum impact on the disease. We use that application to different cancers.
Is that pretty well covered? How many people heard Dr. Tu when he spoke a couple months ago? He talked about the heart, and he convinced me that if you take care of your heart, that's still #1 killer.
In terms, yeah.
By a lot. He said if you led a lifestyle to keep your heart healthy, a lot of this stuff would be
Correct.
minuscule because you're living a better lifestyle, I think.
Definitely, your heart is important especially for women. Actually, it is very important because for guys we know the heart problems, and I think that the stress for women has not been that out there. But yeah, your heart is pretty important. Like heart and overall cancer, those are the two things competing to be #1 and #2.
Okay, let's give the doctor a hand. You can check